Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thank you. So I know this was titled Vaccines in People with HIV, but I wanted to just focus the entire time on pneumococcal vaccination. I don't have any conflicts, and here are the obligatory things. I don't have any trade names that I'm going to be talking about. I really wanted to use this as a title because it is so darn confusing. And you can replace darn with whatever expletive you want to use, but I feel like it's been unnecessarily so confusing for vaccinating our patients. And for a brief period of time, it was sort of simplified, and then it got more complicated again. So I wanted to go through some of the recommendation changes since last, I think in October of 2022, there was some new guidance that came out. And so the reason for the change, and I think I've talked about this before when PCV20 first came out, is that in cost effectiveness analyses, it was felt to be cost saving rather than using multiple different products and in terms of risk stratifying who gets the conjugate versus not, and then offering a higher level of protection for invasive pneumococcal disease and addressing some equity concerns that were present when we had more generalized shared decision-making about using the PCV20. And I put an asterisk next to simplify recommendations because I feel like that was the original intent, and then I felt like I think they got rid of that as a goal of changing these recommendations. So just to underscore the differences in coverage of the different vaccines that we have. So PCV13, which is what we had all been using since around 2013 or so, covers, and it's the conjugate vaccine that covers 13 serotypes. And then just a couple of years ago in 2021, we had recommendations to update to PCV15 and PCV20. And you can see the additional coverage of the serotypes there. The polysaccharide 23-valent has been around for quite some time, as we all know, and that had been the main vaccine for adults, and we weren't really using conjugate vaccines. Those were really for peds populations up until about a decade ago. And you can see that there is more types, obviously, that are covered, but we've moved on to the conjugate vaccines because they do offer better protection. And we've seen that in the pediatric population for a long time, that these are generally better immunogenic vaccines. So we also know that when we look at invasive pneumococcal disease in immunocompromised hosts, and these are immunocompromising conditions, a broad range of them like asplenia, et cetera, that you can see the percentage and the type that you can see. So about 20 to 30% or so of the invasive pneumococcal disease are the kinds that were in the 13-valent, but we were still missing a lot. And so what's covered in the PCV20 that's not in the PCV13 is an additional nearly 30%. So offering potentially protection against close to 60%, or at least 50% of invasive pneumococcal disease with the usage of the PCV20 rather than the PCV13. We have data for the use of PCV15 in people with HIV. We don't have that directly for PCV20, but there's no reason to think that it won't work in our patients. So questions here. Thanks, Pam, for doing this so quickly. Which of the following is most appropriate here for this 43-year-old woman who has a recent diagnosis of HIV? She's now on ART. She notes that she's received all her childhood vaccinations and she's a non-smoker and has not had any other medical problems. So which of the following is most appropriate regarding pneumococcal vaccination today? She doesn't need any additional pneumococcal vaccine as she received it as a child. Give PCV20 today, give PSV23 today, or give a PCV20 followed by the polysaccharide 23-valent in a year. So I'll give a minute for people to weigh in. Great. So most people have been doing this for a little while now, that we have been giving PCV20 and being kind of one and done with our vaccination. So for this particular case, it's easy. This is a simplified recommendation than what we used to have, which was give the 13-valent and then give another, 8 weeks later, give the polysaccharide, and then again in 5 years, and then again when they're 65. There was a lot of things to remember about that and different vaccine products. This makes it a little bit easier. So the ACIP recommendations are to give a PCV20 or a PCV15. And I'm curious, in the ECHO community, how many clinics are carrying PCV15 instead of PCV20? If you carry 15, unfortunately, you're going to still have to give a polysaccharide vaccine. And that's because, we're covering less serotypes. And so the recommendation by ACIP is to broaden that coverage of serotypes by giving the 23-valent. If you give the PCV20, you're practically there anyway. And this is a good, robust vaccine. So there's not thought to be that you need any other vaccine. So if you're carrying PCV20, it makes it a lot easier. So what about a slightly different case? A 63-year-old individual presents for routine follow-up for HIV. They've been on ART and viral load's been suppressed. They ask about the pneumonia vaccine, as they're very pro-vaccine and have heard that there is a new vaccine available. You note that they received PCV13 in 2013 and the polysaccharide in 2014 and again in 2019. So following that, vaccine schedule that we used to have. Which of the following is most appropriate regarding pneumococcal vaccination? No further vaccine is recommended as they received the complete series. Offer PCV20 at age 65 through shared decision-making. Offer PCV20 at age 65, or give the polysaccharide at age 65 to complete the series. Okay, a little bit more of a split here. A very few of you thinking no further vaccine is needed. A majority of you wanting to give a PCV20. And then some of you wanting to give another polysaccharide vaccine. So let's talk about this a little, because I think this is where some of the confusion comes in and a lot of if-then kind of recommendations for individuals 65 and over. So this is the recommendation, and I've grayed out some of the things where the ACIP says you can give either, but I think most of us want to give the PCV20. So even though these are equivalent recommendations, I've sort of grayed them out a little bit. So for individuals 65 and over, it's a little bit more confusing. If there's been no prior vaccination for pneumococcal disease, it's the same as someone under 65. Go ahead and give the 20-valent, the PCV20. If they've received only the polysaccharide, then you can go ahead and give PCV20 or PCV15, which I can gray out there too. But since none of you are carrying PCV15, I'll just focus on PCV20. So if they've never gotten a conjugate vaccine or they've never been vaccinated, it's fairly straightforward. You can just give the PCV20. If they've received a conjugate vaccine already, but they haven't received a polysaccharide vaccine, so essentially they've just gotten a PCV13, you can go ahead and give the PCV20 a year later. If they've received PCV13 at any age and a polysaccharide vaccine before the age of 65, you can go ahead and give the PCV20 at least 5 years after their last pneumococcal vaccine dose. If they've received PCV13 at any age and a polysaccharide vaccine at or after age 65, then that's when you do shared decision-making. So this is what's creating a lot of confusion, because there's a lot of if this, then that, and also there's a difference in wait periods. So as you can tell, if they've gotten a conjugate vaccine before, or they've completed their series before, I should say, they should wait 5 years to get their next pneumococcal vaccine. So in this case of this individual, you can offer the PCV20 at age 65 because they completed their series and their polysaccharide vaccines were before the age of 65. What about a person who has well-controlled HIV and has just gotten a polysaccharide vaccine once in 2019? He's under age 65, but has not received any pneumococcal conjugate vaccine. Would you go ahead and give the PCV20 followed by an additional dose of the polysaccharide 8 weeks later and at least 5 years from the last polysaccharide vaccine or from that first polysaccharide vaccine, or give PCV20 and no additional doses are recommended? Great. So as I mentioned, in this situation, basically, if you give PCV20, then you really don't need to do anything else. In this situation, even if you didn't have PCV20, you could get away with just giving one PCV15 because they'd already gotten their polysaccharide. So there's no further doses of polysaccharide recommended. So how about the opposite? If they've received conjugate vaccine in 2019, but have not received any other pneumococcal vaccination. So would you give PCV20 and no additional pneumococcal vaccine? Would you give PCV20? So the first one should be give PCV20 followed by the polysaccharide 8 weeks later, or give PCV20 with nothing else, or give polysaccharide followed another 5 years later by another polysaccharide. Okay, so this one is a little bit confusing. So there's kind of two answers to this one. And I grayed out the one that I don't like as much. So that's why, and ACIP, either one are options. So to simplify things, like I said, I would just stick with the PCV20. But for immunocompromised individuals, ACIP has also given an option of giving essentially 2 doses of the polysaccharide vaccine instead. And this is really confusing because in all the other scenarios, we're prioritizing the conjugate 20. And so that's why I've sort of graded out to try to simplify some of these recommendations. But in this situation, B, which is what the majority of people put, but you can also do C. I think most of us are phasing out the availability of polysaccharide vaccine in our clinics. How many of you are still carrying polysaccharide vaccines? And in what situations are you using them? Okay, it's okay if you don't want to share. Okay, so the last 2 slides are really these are from ACIP because I think they recognized how confusing this all is for people. And so they've created some nice graphic images. This is similar to what David Spock would have put together, I think. Or maybe they consulted David, I don't know. But this sort of just are easy ways to look at this. And I put a web link to these resources as well to try to make it easier if you have any concerns. But you can see here in most individuals, you can give PCV20. There's an option B, and the time intervals are what you focus on. So it's most likely a year, but in some situations, if it's 5 years. So I would highly encourage you to look at this. And this is the recommendations for 65 and older. Favor one option over the other. They are equivalent recommendations, but here that's why they're called option A and B versus alternative options. One of our primary care doctors in the clinic was telling me how confusing it is and that she downloaded this app. And I don't know how many of you have used this app. I haven't really used it, but she uses it every time, she says, because she says, I'm never going to remember this. And this app allows me to just enter the patient information and spits out the recommendations based on the updated recommendations from this year, 2023, and when the schedule comes out in February. So I just put that up there if people want to use it, and not just for people with HIV, but for anybody in your practice, since the recommendations can be a little bit confusing. And then the web address above it is actually the ACIP one where it walks through each scenario, and then also the tables that I showed.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.